Hello and welcome to the Learning Management System Module 6 training. This module is all about treating sleep apnea in the dental office and how to work with your patients and identify patients who had no idea they had sleep apnea, and also how to work with patients who know they had sleep apnea but have been unable to successfully treat it using the more conventional recommendation, which is the CPAP machine. My name is Dr. Disher, and I've been your trainer now through the entire process of all the modules. And again, welcome to Module 6. So many of you are very, very excited to begin. We're very excited for you. Some of you have had quite a bit of experience treating sleep apnea in your practice. Others of you are brand new. So I want to just start off saying I will be treating this webinar as if you are brand new to sleep apnea. The main focus of this webinar is going to be clinical as opposed to administrative, but there is a ton of information in your back office on how to get your office set up, and including how to set up hardware, in other words, the pulse oximeters, the home sleep testers, and then also insurance issues are dealt with all in various points along the training here. So you have a wealth of information already here in the LMS, the Learning Management System. Please make sure that everyone in the office becomes familiar with everything in the back office. As you can see, there's a ton of information back here. Okay, so let's begin. It's very, very important that everyone in the office knows a little bit about sleep apnea and has a basic understanding of why we should even bother doing any of this. Because, you know, sleep apnea is a very, very severe condition, and it can take the life of our patients prematurely. So we want to make sure that everyone in the office does understand that this is a very serious matter for patients who are either at risk or are actually suffering from sleep apnea. And, you know, just as a quick example of how important what we're going to be doing is for our patients, we can reference this slide right here. You know, the prevalence of sleep apnea among cardiovascular patients, in other words, patients with heart problems, right? Everything from heart attacks to any other particular cardiovascular disease situations. Sleep apnea is very prevalent, more prevalent, 2 to 3 times more prevalent among those patients. And it's also been found that 91% of stroke patients also have sleep apnea. And that's not a coincidence. Why is this? Well, when we stop breathing, a couple things happen. You know, we release epinephrine. We go into a sort of a fight or flight mode, and blood pressure increases, heart rate increases, the strain on our lungs as we try to pull in air through a blocked passage, all big problems, and creating massive health issues for our patients who are sufferers of sleep apnea. So again, very, very important that all staff members and doctors who don't have any previous experience do establish their foundation, go through all of this information in the back office, take each of the assessments at the end of each section so that we can be sure that you do have that basic understanding of what's going on. We have information back here regarding sleep apnea signs and symptoms, the 3 different types of sleep apnea. Let's look at signs and symptoms here. Okay, we're talking about screening in our office, very, very important. And here's our signs and symptoms. Okay, we've got snoring, daytime sleepiness, hypertension, acid reflux, morning headaches. All of these things are a sign, a symptom that your patient is potentially suffering from obstructive sleep apnea. And of course, we have contributing factors: obesity, large neck circumference, aging in the female population, and those women who are in menopause, and then of course mouth breathers as well. So don't be fooled though. These are not the only indicators that your patient is at risk. We have many young male patients, slender in build, who have severe sleep apnea. And the reason is there are anatomical considerations that contribute to the occurrence of sleep apnea as well. So you could have a very small airway. You could have a lot of tissue in the posterior pharynx area that is able to collapse and close off the airway. You could have a large tongue with a small, narrow palate, so not a lot of room for the tongue in the mouth, and it tends to naturally fall back and close off our airway. So a lot of different types of patients. You'll see all kinds, ages, and sizes of patients suffering from sleep apnea in your office. And that's why it is so important that we screen and look for signs and symptoms, and then send patients home with screening devices so that we can determine what's going on with their oxygen level while they're sleeping. One of the main questions we'll ask patients in our office is, has anyone ever told you that you snore? And the reason we word the question in this manner is that you'll get more honest answers regarding this as opposed to asking the patient, do you snore? Because most patients, when they start to think of it from a first-person standpoint, do I snore? No, I don't snore. Don't forget, patients are sleeping when they're snoring, so most are not aware of it unless someone has told them. So much better question to ask is, has anyone ever told you that you snore? And you'll get more frequent correct answers when you ask in that manner. But snoring, 40 to 60% of adults snore, but doesn't mean they have sleep apnea. They may only have slightly restricted airway during that time and not require treatment. But how do we know? We don't know unless we send our patient home minimally with a pulse oximeter so that we can monitor their oxygen level at night to see if it's falling below a certain point where it becomes dangerous. Also, don't forget, sleep apnea creates another problem for patients, and that is excessive daytime sleepiness. Many of our sleep apnea patients will end up having car accidents because they've dozed off while driving. This is a big, big problem, and that is another way we can help save the lives of our patients by identifying and then getting them the correct treatment for their sleep apnea. Okay, so just as a reference, I want to open up all of these tabs over here so that you can see that office setup and hardware. We talk about different billing options that you have for patients, all about how to use pulse oximeters. You can see there are movies in here. Please take advantage of watching these, view them multiple times or whatever is necessary, and there are some very important forms back here as well. Okay, this is a good form to hand to any patient that you send home with your pulse oximeter, because these are not inexpensive units. The replacement fee for a lost unit is $440. We do have our patients fill out these forms so that they do have a sense of responsibility, because in the past we have had patients simply not return the device. And you do not want to have a dwindling number of pulse oximeters occurring in your office. Okay, so as we begin working with our patients in our practice, we are going to start with our existing patients. Why? Well, they trust us. We can work easily with our existing patients, and believe me, you will discover many of your patients are suffering from sleep apnea. This also gives us an opportunity to work through how do we make these devices with patients who love and respect us and are not looking to see an expert coming in and finding that they're we're having a difficult time making an appliance. So we want to get our fingers wet, so to speak, on our existing patients, work out the bugs with patients who have respect for us and who understand who we are and what we can do for them. And again, very, very important to do that with our existing patients before we have patients referred in, before we begin to advertise externally for patients such as patients who are CPAP intolerant, which is a very large number of patients that you eventually do want to tap into. But first, we want to work out all the kinks with our existing internal patients. We want to start slowly and begin to ramp things up, just like any new procedure in any office. Okay, so I did say I wanted to focus mainly on the clinical aspect of how do we once we screen our patient and have identified them, what do we do next? So there's a little bit here about a complimentary consult, and also we want to make sure we inform our patients about what their sleep apnea treatment options are once we have identified a patient in need of sleep apnea treatment, right? They need to know what all their options are, and they need to be informed, and that patient should sign that, and it should be copy should be kept in the chart and one given to the patient as well. Okay, so I'm clicking on these forms back here. These are very, very important. This will make your record keeping very simple to do. In my office, I have all of these forms printed out and set up in little packets in the correct order in which they need to be filled out. So the first visit for our patient is the sleep exam notes, and we'll fill in the patient's name, if they were accompanied by anyone, if they are a CPAP patient that is intolerant to the CPAP, we'll mark off that we have reviewed sleep study results with the patient. So if we've done a pulse oximeter in our office and have moved that patient forward to see a pulmonologist to get an attended sleep study, or if we've done an in-house home sleep test with the patient and gotten that professionally read by a pulmonologist or a sleep tech, then we make sure that we have reviewed the sleep study results with the patient and that the patient understands the results of the test. Some other check mark points, you want to run through these and check off that you've done all of these things and that you haven't missed anything in terms of talking with our patients. Okay, we're going to get into talking about the Snore shim test in a little bit. I'll show you some pictures of your shims, and I'll talk a little bit about how we work with those. Very, very important in terms of determining how to fabricate our sleep appliance. We're going to also mark down our Epworth sleepiness score on this form, take the patient's vitals, make sure that those are all entered, and check their range of motion of their mandible so that we can also determine that fabrication of a sleep appliance is appropriate for our patient. We're also going to talk a little bit later on in this webinar about different appliance options, and we can talk to our patients about what their choices are in terms of what type of appliance they could have made for them. We're going to write our initial clinical impression, which may be as simple as the patient would benefit from oral appliance therapy, the recommended next treatment listed here, and then you want to mark down the doctor's name and how much total time was spent face-to-face with the patient, and how many minutes of that time was spent counseling and coordinating care regarding sleep apnea therapy. So typically we would then make an appointment for our patient to come in to have sleep records taken. Okay, again, name of the patient goes here. We want to take a panoramic image so that we at least can view the TMJ and supporting structures. Did we take our impressions? Yes or no? The bite registration was taken at, and this is how many millimeters vertical opening. And also if you took the bite registration at an edge-to-edge position or if the patient was retruded a certain number of millimeters or protruded a certain number of millimeters. Okay, we like to take intraoral photos to document the patient in the biting position, and then we make sure the patient has signed a sleep consent form. Okay, the consent form. So during this visit, the dentist is determining the correct vertical for the patient and also taking impressions and taking any image records that are necessary. Oh, here's the intraoral appliance patient consent form. I typically will have the patient read through this actually prior to taking my impressions, just in case there are any questions or issues regarding the information in the consent form. And I will even do this during the exam visit so that the patient is aware what the pros and cons are of appliance therapy, the advantages and disadvantages of appliance therapy, so that when we get to our records visit, we're already certain that the patient is moving forward with treatment. So during our exam visit, we're talking to the patient about the potential benefit and how a sleep appliance works. And it's very important that we use our Snore shim made by Airway Metrics. And these come in various vertical dimensions, as well as allow for the incisal edges of a maxillary incisor and a mandibular incisor to fit into these grooves so that we can put the patient in an edge-to-edge position or make them have advancement. But once we find a vertical dimension that is appropriate for the patient, we will notice that when the patient attempts to make a snore sound, they will not be able to, or they will have a more difficult time creating that snoring sound. And that's how we know we've attained the correct vertical dimension for the appliance to be fabricated in. So as an example, I'll start with the smallest shim, which is a 4 millimeter vertical. And I like to do this where patients are putting their maxillary incisor in the center groove and the mandibular incisor into a center groove here, so that they are in an edge-to-edge position with the shim horizontal to the floor. Okay, so if patients tilted back, that doesn't apply, but if they're sitting up straight, we want this bite shim to be as horizontal as possible. So once we have the bite shim in place, we will lean the patient back, put them into a reclined position, and ask them to make a snore sound. And then we'll move up to the next shim and ask them again to repeat that, make a snore sound. Again, with the next highest shim, until we find one where the snore sound is either reduced or eliminated. And that's how I will choose in my practice the vertical dimension at which to take my bite registration. Okay, once we've determined that, let's say it's the 6 millimeter shim that works best, I will place the shim between the patient's upper and lower incisors and then use a fast setting bite registration material and squirt the bite registration material up and down between the upper and lower teeth until the space is filled with bite registration material. And then I'll wrap the bite registration material around the shim and complete the bite registration over to the opposite side of the arch. Okay, once that material is completely set, we remove the entire thing from the patient's mouth, and then I will slide the shim out of the bite registration, make sure it is disinfected and placed back into the Airway Metrics kit so that none of these ever go to the lab and none of them ever get lost. Okay, so moving forward in the clinical sequence, once we've got our patient done the exam and gotten the patient consent, and then we've begun taking our sleep records, we take our impressions, we've determined the correct vertical dimension for our bite registration, and taken that bite registration, we want to discuss with our patient which type of appliance might be best for them. So let's talk a little bit about sleep appliances for the moment. So one of the original and most well-known sleep appliances is the TAP appliance. So the TAP appliance has had several evolutions. the most recent up until about, maybe 8 months ago was the TAP 3 Elite. In the TAP 3 Elite, you had an upper component with a hook and a lower component with a bar. The hook would engage onto the bar, and as you advance the hook, it would move the bar and the mandible as well forward as the patient was sleeping, and hold it in that forward position. So when the patient is wearing it, it would look something like this, right? And so here you can see what I'm talking about when I say we use these bite shims, because here we have a vertical dimension of perhaps 6 or 8 millimeters opening that this particular dentist has determined is proper for his patient. But since the TAP 3 and the TAP 3 Elite, there's been a new evolution, and TAP, as far as I understand, has stopped making the TAP 3. Okay, but some of the disadvantages of the TAP 3 is that you cannot open your mouth while you have the appliance in. But you do have some lateral side-to-side motion. Okay, the most recent evolution of the TAP appliance, which I believe now is the only version that TAP makes, is the Dream Tap. And it might be a little difficult to see, but what TAP has done is taken the bar and moved it onto the maxillary arch. When the bar is in the maxillary arch and the hook is on the lower, now as the hook is retruded, it brings the mandible forward. So when we adjust the hook, we're actually pushing the hook more posteriorly, but since it's on the bar of the maxillary teeth, which are fixed, it actually, as the hook goes back, it pulls the mandible forward. Okay, again, same disadvantage with this appliance. Patient cannot open when they're wearing it, but they do have some side-to-side lateral mobility. Okay, so if you have a patient who is a strong bruxer and they grind from side to side at night, this appliance may be best for that patient. If you have a patient who tends to feel claustrophobic, this appliance may not be the best choice for the patient. I'm going to talk about some other appliances that do allow you to open. And many patients feel that the ability to open their jaw is much less constricting and makes them feel more comfortable and more relaxed when they're wearing it. I just want to see if we can get one more image of the Dream Tap, maybe one that's not so fuzzy. Okay, so here it is again. And you get the basic idea. Hook is on the bottom, bar is on the top. What this has done with the TAP appliance is actually gives us more tongue space, which is a good thing. That was one of the drawbacks of the TAP 3, is that the bar was sort of in the way of the tongue, and it would take up some of the natural tongue space that we want to maintain for our patients while they're sleeping. Okay, here's another image of the Dream Tap, and what you can see is that the hook will fit onto the bar up top and have some ability to slide back and forth. Now, one drawback I have found with the Dream Tap is that since the bar is now in an arch shape, the hook, as you begin to advance the mandible further and further forward, the hook has a tendency, as the patient relaxes and goes to sleep, to slip off to one side or the other, and that defeats the advancement that we've achieved with the hook. So that can be a slight disadvantage of this appliance, although I have quite a few patients wearing these successfully with reduced sleep apnea symptoms. Okay, so an appliance that allows you to open while you're wearing it, but has the limitation of very little side-to-side mobility, is the Somnodent appliance. Okay, and Somnodent has come up with some very nice features. One of the nicest things about Somnodent is that it takes up very little tongue space. A very unobtrusive appliance. Patients can open, and they have developed this version of the Somnodent called the Somnodent Flex, which allows you to change out these fins. Okay, so the way this appliance works is as the patient's wearing it, the fin rides up against this acrylic block and keeps the mandible in a forward position, prevents it from falling back while the patient is sleeping. And the advancements are done bilaterally. Okay, so one advancement here is done simultaneously with another advancement on the opposite side as well. So this appliance is slightly more tricky to advance. The TAP appliance only has one adjustment to make. The Somnodent has two, one on each side. And obviously you want to advance both of these blocks at the same distance at the same time, so that when the patient does engage the block with the fins, that it's not throwing their jaw off to one side or the other slightly. Okay, so we do have to have detailed use instructions when we insert the appliance for our patients, and we have to be very particular, make sure the patient really does understand what we're saying, and actually have them show us how they're going to make the adjustments to the appliance before they leave the office. Okay, so Somnodent uses fins. Because of the fins, we don't have much lateral movement. So on a heavy bruxer, I have had heavy bruxer patients snap these fins off. It's not fun because you got to send the appliance back and or talk with the patient about making a completely different design for them. Okay, so we want to review this with our patients and make sure that we make the correct choice and best initial choice for our patients when we are making the decision on which appliance to fabricate. Okay, incidentally, impression techniques for Somnodent versus TAP versus EMA versus Narval, all the same. So we take the same types of impressions, upper, lower, and the same types of bite registration to establish our vertical dimension. It doesn't matter what type of appliance we're making. We'll just send our impressions to the correct lab to get the correct appliance, and of course with the correct lab prescription. Okay, some of you may be familiar also with the EMA appliance. This appliance utilizes elastic bands that are attached to the upper and lower tray to keep the mandible in a more forward position. So these elastic bands come in longer and shorter distances. They also come in varying amount of stretchiness to them. So some are very stiff, others are a little more stretchy. Okay, this is a fairly inexpensive appliance to make compared to either the Somnodent or the TAP appliances, which both run in the $400 to $500 range. Okay, that's lab fee. This appliance typically can be fabricated for less than $200, depending on your lab, and it actually shows in the feel and the quality of the appliance. In my opinion, this is a much flimsier type of appliance, but it does a couple of things, and I just want to talk a little bit about this appliance. There's a couple of things the other appliances can't really do. This appliance does allow the patient to open and have some ability to open, and it does allow for lateral movement as well. Okay, it's not as restrictive feeling as either the TAP or excuse me, or the Somnodent in terms of lateral movement, and it's not restrictive at all in terms of for the patient being able to open. All right, so when might we choose something like this appliance, like an EMA appliance? We might choose an EMA appliance for the patient who's both a heavy bruxer and somewhat claustrophobic. Okay, because you will have the ability to go side to side to a degree without breaking the appliance, and also open and close without feeling the same restriction that you would have with a TAP appliance. All right, so if we've got a patient who is also just does a lot of snoring, we find out that they snore heavily and it's interfering with their lifestyle. They have to have separate bed from their spouse or from their bed partner, then this is a great appliance, fairly inexpensive to create and fairly easy to wear without a whole lot of adjustment necessary, and these are great in terms of reducing snoring. So I want to talk a little bit about the Narval appliance. This appliance works very similarly to an EMA in that it has straps along the side. Okay, these straps are not elastic straps per se. They're made of not a stretchy plastic, but a more rigid type of material. So they're non-elastic. And the appliance itself is actually made from Kevlar. So it's a very tough and durable appliance, although it has some of the same characteristics as the EMA. Being flimsy is not one of them. You will also notice it is very, very thin. So it is great for patients who need a maximum amount of tongue space. Okay, you can see that the anterior component of this, none of this extends onto the lingual side, so there's really no intrusion on tongue space. It's one of the main advantages of the appliance. Okay, but also a much pricier appliance compared to an EMA. So this appliance is going to run you in the $500 to $600 range to have fabricated. All right, so again, I will have a discussion with my patients regarding sleep appliances and the type of sleep appliance that may work best for them. I don't give patients 17 different choices, although there are many, many other brands of sleep appliance. I give them some basic choices, and I only give them choices after I have asked them a few questions, such as, do you feel claustrophobic? If your appliance held your teeth together in one position all night long, do you think that would bother you? I also want to find out if they clench and grind. And so knowing those things, I will sometimes simply guide my patient to what I think is the best appliance, but also have a short and brief discussion with them about the two different types of appliance, one that allows you to open and one that allows you better to go side to side. And if they think they need both of those, then we may talk about the Narval or potentially an EMA appliance. One drawback of the EMA is that it is only adjustable in 1 millimeter advancement increments. So with the DreamTap and with the Somnodent, we can make advancements in 0.25 millimeter increments, so 4 advancements per millimeter. And because of that, we have a lot more variability to walk our patient into further advancement slowly. Believe it or not, when you begin to encroach upon 70% of the patient's range of motion in a protrusive manner, then you begin to get to a place where you may not want to move a full millimeter in one fell swoop like you'd be forced to do with an EMA appliance. You may want to move only a quarter of a millimeter at a time to allow the patient's muscles and ligaments and tendons to adapt to the more forward jaw position. So for that reason, the Somnodent and the DreamTap have an advantage over, say, the EMA or the Narval. Okay, let's go back and look at further progress in now we want to deliver this appliance. We've had the appliance fabricated, and we want to go on and talk about the delivery appointment. Okay, so this form will be in my chart for the patient. There's a checklist of everything that I need to be sure of here. The type of appliance, the patient presenting for sleep appliance delivery, the lab, the appliance type, what material, and the material is important only if we're talking about different types of liners inside of the appliance. Most of these appliances are triple laminate, and you will see triple laminate indicated by the letters TL after the appliance. So if you see TL, that means triple laminate, and that just tells you there's a soft liner that engages the teeth, as opposed to a hard acrylic liner or a thermoplastic liner, which you can heat with water and reshape and reform it as needed. Okay, so hooked obviously only applies to appliances with hooks like the tap appliance, and this is to indicate whether you use the standard hook, which is called the Class 1 hook, or the Class 2 hook, which is a longer hook and gives you more advancement. We want to make sure that we give our patients an advancement log and we review the instructions on how to make the advancements with their appliance, because we want them to start in a very comfortable position and move slowly towards the ultimate goal of advancement, which we have predetermined with the patient using the appliance and taking measurements of their current range of motion in the protrusive fashion. So we've got, let's say a patient has 10 millimeters of protrusive mobility and they can push their jaw forward 10 millimeters. We don't want to encroach typically further than 7 to 8 millimeters at the most of advancement. Most patients who have 10 millimeters of protrusive movement can tolerate about 7 millimeters of advancement on an appliance, but usually we need to work our way up to that level of advancement. So we'll determine a comfortable starting position for the patient. It might be 10 turns on the appliance. We'll just determine how many advancements will be needed to hit our goal location for the patient, goal of advancement. So if they start at 10 but they need to get to 40 turns or 30 turns, then we'll mark that here. Advancements needed would be, if they start at 10 and we want to get them to 30, they would need 20 advancements, just as a simple example. We want to make sure we've given them the wear and care instructions, which we have forms for that in the back, how to care for your appliance. Okay. We want to make sure and check that we have reviewed with the patient how to adjust the appliance at home. We also want to make sure they can take it on and off easily enough. And we're going to fabricate an AM positioner for the patient and also instruct them on how to use it. Now the AM positioner or AM aligner is going to be used by the patient in the morning when they remove their sleep appliance. They're going to place the AM aligner on the maxillary teeth and close their jaw until the mandibular teeth interdigitate into that AM aligner, which records their natural centric occlusion bite. Okay, we want to make sure they do this every morning, and if they feel their teeth are not coming together properly, they need to go through the exercise regimen using the AM aligner, and all of those instructions are listed in the AM aligner packet. Let's go ahead and look at the AM aligner right now. Okay, so the AM aligner comes as a wafer. And we heat this wafer in water that's about 160 degrees, and it takes about a minute to a minute and a half to become soft and moldable. When it's soft and moldable, you'll pick up one end and it'll just kind of flop over like a wet noodle. So what I'll do is I'll have the patient lean back. I'll tell them to demonstrate their bite for me. I'll make sure they're biting correctly. And I'm going to tell them, I'm going to place this wafer between your teeth and I want you to bite through it. Okay, and I confirm visually that they are actually biting correctly into their normal centric occlusion bite. Okay, once I've confirmed that they've bitten into the AM aligner properly, I begin to mold the material up along the buccal surface of the upper teeth and leave a little bit of a handle tilted down in the front so that the patient has a place to grab it. Okay, I'll also instruct the patient to use their tongue so that they can bend the lingual portion up against the palate. Okay, it's more comfortable for the patient when that material adapts to the palate. Okay, so the patient will adapt the palate side, I adapt the buccal surface, and then I just will use my air-water syringe and cool it with a stream of air. It takes longer to cool than it does to soften. So be patient. Okay, and once you have this hardened, have the patient try it in a few times, take it on and off a few times, bite into it, make sure that their bite feels correct, and then go over the exercise instructions with the patient. Okay, every AM aligner packet comes with the use instructions inside. It's a very simple exercise regimen, and I tell my patient, if your teeth don't feel right in the morning and you're using the AM aligner, go ahead and feel free to do the exercises while you're taking a shower, while you're doing your morning routine. You don't have to stop what you're doing and focus on this, because it's not something that requires total attention. So it's not going to add any extra time to the patient's morning routine. Very important, we explain to the patient that if their bite does not feel correct and they don't use the exercises, they may end up with a permanent change in the way their teeth come together. Okay, so it's very important that we fabricate an AM aligner for every patient receiving a sleep apnea appliance. Okay, so the AM positioner was fit and adjusted. We explained how to do the morning exercises. We want to make sure we give the patient also the written instructions, a copy of those, and make sure that they're comfortable placing and removing the appliance before they leave the office. Okay, we have a spot here for assessment notes and our next visit, and then of course our signatures at the bottom. All right, so if we have an appliance that the patient is going to make their own advancements at home, such as a DreamTap or a Somnodent appliance, we're going to give them an oral appliance advancements log sheet. I put their name at the top. We're going to put the date the appliance was delivered, and the starting position. I don't count it from full protrusion. I count it from the 0 position of advancements. So I always cross this off and say from full retrusion. Okay, so my starting position, like I gave in the first example, if my starting position is 10 turns, I'll put 10 here, and then I'll tell the patient what to do with this log sheet. You fill in the date, and on the evening that you make an advancement, you put a 1, or if you make 2 advancements, put a 2 in the plus column. And the next morning when you wake up, you can write any notes. Oh, I was uncomfortable, or I was perfectly comfortable, but snoring hasn't changed. Great. So the next day you're going to make another advancement. And make notes if needed. Okay? If I tell a patient if they get in, they get maybe 5 or 10 advancements in, and then morning after they feel like they've got some tension in their jaw muscles, they should make a note here, and then they can go and use the minus column for the next evening and go back 1 turn so that they can sit at a more comfortable advancement position for a few nights, make no advancements until they feel comfortable, and then try again to make 1 more further advancement in the plus column after they've had a few comfortable nights wearing their appliance. Okay, so this is back office information regarding the purpose of the AM aligner. Go ahead and read through that at your leisure. We've basically gone through that at this point, so I'm going to move forward now we've finished with the appliance delivery, and you've given your patient the home care instructions. They take it home. I want to see my patient back, and you should too, see them back 30 days after insertion of the appliance. Okay? I always tell my patient, if you're having difficulty or discomfort before your return visit, please call us and we'll help figure out what's going on. Okay? If a patient has an appliance delivered, and I tell the patient, if you get 1 tooth that starts to feel sore, that means I need to adjust the appliance in that area. If you have all the teeth feeling a little bit sore at night, or excuse me, in the morning, that means the appliance is snug, and it's just an adjustment period that you give it a few days and your teeth will be comfortable again. Okay, so I tell them, if you get 1 sore tooth, let me know. I'll make an adjustment. If you have most of your teeth feeling a little sore in the morning, that's because the appliance is snug on the teeth, and just give that a few days, and that typically resolves on its own. Okay, so when our patient comes back in 30 days, we want to make sure that they have their advancements log sheet with them, because we want to see how much progress they have made. Of course, some patients will forget to bring it, in which case, as long as you have their appliance, you can count the amount of advancements and go backwards and count how many advancements they made in the appliance. All right, so again, sleep appliance check notes. So this is for the dentist to fill out, but what we'll do before the dentist goes into the office is give the patient a progress questionnaire to fill out, okay? So typically, I'll have my assistant fill out the patient's name, the date the appliance was inserted, the design, the material, and the hook if appropriate. Then I hand the patient the form and ask them to answer the questions. Do you wear your appliance every night? When you wear it, is it comfortable or uncomfortable? Okay, and then I can pick this up when I walk in the operatory, and I have a very good idea of what's going on with the patient and their sleep appliance. Okay, so I can address any issues they might have immediately and without taking a whole lot of time. Okay, also this form filled out by the patient will help me when I go to fill out my form, which is the check notes. Okay, is the patient wearing it every night? When they wear it, are they comfortable or uncomfortable? How are they doing with the appliance? How's their energy level? Patient is sleeping better, worse, unchanged. If their sleeping partner is with them, we can ask the sleeping partner to tell us how they think the patient's doing. Oftentimes the sleeping partner will report to us that the amount of snoring is significantly less and they're very, very happy. So make sure you fill this out and keep it in your record. Also listing the doctor's name and how much time total and how much time spent counseling and coordinating care. All right, so we'll see our patients back and we'll typically fill out 2 or 3 of these check notes forms. So we've got a 30-day, a 60-day, a 90-day check of the sleep appliance progress and the patient's usage of the appliance. Okay, once we get the patient titrated to the position we want them to, and the patient's feeling good and comfortable with their appliance, then we want to go ahead and do some follow-up, which is a Medibite on the patient wearing their sleep appliance. So we'll send them with an HST, we'll instruct them how to use it, and have them wear their appliance and the HST, home sleep test device, so that we can get a good feel for how much improvement our sleep device is providing for the patient. Okay, so this observation of sleep scale form is great if the bed partner is with the patient on one of the check visits, okay, because the sleep partner can often tell us what's a little bit more about what's going on with the patient. Since the patient themselves are sleeping, they don't necessarily know if they're having any choking spells or if they pause breathing. But a sleep partner does typically tend to notice these things. Okay, so observation of sleep scale is for the bed partner if one comes with the patient. Okay, so in your existing patient population, you may find patients who were previously diagnosed with sleep apnea and instructed to wear CPAP, given the CPAP, instructed on how to use it, and took it home, and they were able to use it for a few weeks because they forced themselves to do it, but ended up giving up because of one of various reasons, whether the mask didn't fit properly or the noise from the device disturbed them, or they felt claustrophobic. Whatever the reason for the intolerance is, you may find many of your own patients, unbeknownst to you, have been recommended to use a CPAP because they have sleep apnea. So it's going to be a great opportunity for you to develop even better relationships with your existing patients by addressing this treatment need that they have, because the best alternative for patients with even with severe sleep apnea that don't tolerate CPAP is an oral appliance. Oral appliance is far better for severe sleep apnea patients than no treatment at all. Okay, so we don't tell our patients that a sleep appliance is going to cure their sleep apnea, especially if they're severe sleep apnea patients, because it's not going to do that. But it is going to reduce the symptoms of sleep apnea and reduce their severity. So they may move from severe down to low moderate, and if we're lucky, we can get a severe patient down to the mild range of 5 to 15 episodes per hour. And if we can do that for any patient who's CPAP intolerant, we've done them a huge service. Okay, many of our severe patients who are CPAP intolerant have an apnea-hypopnea index of 70 or higher, which means they stop breathing and their blood oxygen level falls 70 times per hour. That's a lot of times per hour. Okay, so it makes me wonder when these people are actually breathing. If they stop breathing 70 times an hour and they stop breathing for 30 to 60 seconds at a time, when are they even breathing? So very, very important that we do identify these patients not only in our practice, but then we can begin to even spread the word externally from our practice to market to these CPAP intolerant patients that need our help. Okay, so this is a form that will be necessary, especially if you're processing insurance claims, that we have a CPAP intolerance form so that insurance companies will allow coverage for patients who are intolerant to their CPAP. Okay, so that's a form that you can find in the back office under the additional documents way down here. All right, very good. And with that, I'm going to close out today's webinar on sleep apnea and Module 6. So I look forward to working with all of you in the live training. Please register for that when you have gone through all the information, have a good handle on your hardware, you're setting everything up, how to screen your patients, and all the information in the back office here. After you've gone through all of that and have a good handle on things, please do schedule a clinical webinar live training with me in your back office under the meeting calendar. All right, and I look forward to talking with you guys during that seminar. So thank you very much and have a great day.